This chapter covers respiratory infections from the perspective of a clinical microbiologist working with the clinician who needs to make differential diagnosis of these infections. The chapter is divided into upper and lower respiratory tract infections and discusses the causative organisms and methods of identification. So before we look at the different categories of upper and lower respiratory tract infections, we first need to cover a few general concepts, including the anatomy of the respiratory tract, barriers to infection, and the role of normal flora. The function of the respiratory tract is not only to perform respiration, which is the exchange of oxygen and carbon dioxide, but also to deliver air from the outside of the body to the alveoli, where gas exchange occurs. The anatomy of the respiratory tract includes the entire course that air must travel, from the mouth and nose through the sinuses, into the pharynx, past the epiglottis, through the larynx, into the trachea and bronchi, and eventually into the alveoli. Aside from the function of respiration, the respiratory tract also plays a role in defending the tract against infection. As was just mentioned on the previous slide, this figure depicts the anatomy of the respiratory tract. So air enters through the nasal cavity or through the mouth, and then travels down through the nasopharynx, oropharynx, epiglottis, and larynx, into the trachea, the bronchi, and then eventually into the alveoli. And those are the tiny air sacs of the lungs which allow for the exchange of gas. So here, this diagram also shows you the separation of the upper respiratory tract versus lower respiratory tract, which is the types of infections that we'll be focusing on. So any of the structures above the larynx, including the epiglottis, or oropharynx, nasopharynx, and nasal cavity, involve upper respiratory tract infections, and any of the structures below, such as the trachea, bronchi, lungs, alveoli, those include lower respiratory tract infections. The respiratory tract has many natural barriers along with innate barriers to infection that inhaled organisms must penetrate before they can cause disease. Among some of these elements of the respiratory tract are the nasal hair, which filter the air, mucociliary cells that clear particulates and secrete antimicrobial substances, the mechanism of coughing, which aids in expulsion of particulates, and then normal flora. So these normal biota that colonize the areas prevent infection by pathogenic organisms. Some innate defenses of the respiratory tract include secretory immunoglobulins or antibodies, defensins, which are various enzymes, and phagocytic inflammatory cells, such as polymorphonuclear leukocytes and monocytes that engulf particulates or pathogenic organisms. Alterations in any of these structural or innate barriers can impair their function. For example, cigarette smoking impairs the ability of the ciliated respiratory epithelium to clear particulate, and it also interferes with phagocytic cell activity. Structural abnormalities of various structures of the respiratory tract can result in malignancy or the impaired ability to clear mucus or infectious agents. Normal flora protects the host from infection with pathogenic organisms. Normal flora can prevent proliferation and invasion of pathogenic organisms through competition for nutrients and the same receptor sites on host cells. Some of these organisms also produce bacteriocins, which are bacterial products that are toxic to potential pathogens. The presence of this normal flora keeps the immune system primed for a rapid response to invading organisms and stimulates cross-protective immune factors, such as natural antibodies. Under normal conditions, in a healthy individual, a balance of organisms is maintained that limits the quantity or dominance of any one type of microorganism. As you can see from figure 32.1 in the textbook, there's various normal nasopharyngeal and oropharyngeal organisms present. Bacteria that are usually present include the various alpha streps, so Streptococcus mitis, salivarius, and other viridans strep, along with Streptococcus pneumonia. Beta hemolytic strep can also be present, such as non-group A beta hemolytic strep, and even strep pyogenes, which is group A. Non-hemolytic strep can be present along with various anaerobes. As you can see from the list that are usually present, gram-positive cocci are the predominant organism. Not to say that there aren't some gram-negative organisms, such as Neisseria, Haemophilus influenza, which can occasionally be present along with Haemophilus parainfluenza. And then we also have Actinomycetes, Staph aureus, Mycoplasma, and fungus, such as Candida, that may be occasionally present. An important component in looking at respiratory cultures is distinguishing normal flora from pathogenic organisms. The upper respiratory tract normal flora in an asymptomatic patient may change depending on the clinical setting. Patients who have previously received antibiotics, have been hospitalized recently, or have chronic illness may have different pharyngeal normal flora. An example of normal flora changing over time is Moraxella catarrhalis. This organism was once considered part of normal flora, but can now be associated with some infections, particularly in immunosuppressed patients. When evaluating respiratory cultures, it is important to take into account the anatomical location of the culture. So for example, if alpha hemolytic colonies are isolated from a pharyngeal culture, that can be considered normal flora. Of course, unless the organism is strep pneumonia and it's isolated in very high quantities. But with the pharyngeal culture and strep pneumonia, this is also dependent on the demographic of the laboratory that you're working and the patient population, whether you have normal healthy individuals or a large population of immunosuppressed patients. In regards to the anatomic source, if alpha hemolytic colonies are isolated from a sputum or bronchial aspirate in the clinical setting of lobar pneumonia, full identification and workup would be required, whereas a pharyngeal culture may not be required at all and is routinely considered normal unless the patients are immunosuppressed. As mentioned previously, changes in upper respiratory tract normal flora can occur as a result of broad-spectrum antibiotic use, prolonged hospitalization, and chronic illnesses. Organisms that can commonly be isolated from these types of patients include gram-negative rods, and this may be in the absence of clinical signs of infection. So it's important to distinguish between a positive culture for a potential pathogen that's colonizing the respiratory tract and the clinical disease state caused by the organism. Table 32.2 in your textbook lists organisms that are considered primary pathogens. There's also a number of these organisms that may or may not be pathogens depending on the clinical setting. So from here you can see some of the primary pathogens listed include some of the organisms that we saw that are usual normal flora of the naso- and oropharyngeal tract. For example, strep pneumonia, group A hemolytic strep or strep pyogenes, and Staphylococcus aureus were all listed as organisms that can be normal flora, but they are also considered primary pathogens. Haemophilus influenza was another organism that could be an occasional normal flora, but is also a potential pathogen of the respiratory tract. As mentioned before, some of these organisms are more pathogenic in patients with compromised immune systems, whereas others can typically cause disease in either healthy or non-healthy individuals. Some of the possible pathogens of the respiratory tract include enterics and gram-negative rods, along with Pseudomonas, and some of these organisms that are possible pathogens are typically seen more often with immunosuppressed patients. So again, with respiratory cultures, it's really important to differentiate colonization versus infection. So the interpretation of culture results are based on several factors, such as the method and site of collection, determining if there's white blood cells present, the number of organisms present, and then the patient history. So are there any compatible clinical syndromes present? For example, isolating a few colonies of Staphylococcus aureus from a sputum specimen with many epithelial cells is not suggestive of Staph aureus pneumonia, and it's more likely contamination with an organism that's part of normal flora. But in contrast, if heavy growth of Staph aureus was observed from a respiratory specimen with many white blood cells from an older man with pneumonia, this would be highly suggestive of Staph aureus pneumonia. Other organisms that may be isolated are always considered significant. For example, Mycobacterium tuberculosis. Isolation of this organism in any amount is significant because of the virulence of the organism and the risk for transmission from infected patients to others. As we've seen over and over again, the immune status of the patient is an important factor to evaluate when determining if an organism is the causative agent of infection. Aside from the patient's immune status, the virulence of the organism isolated itself should be evaluated. In immunocompetent individuals or healthy patients, infections normally will follow a normal course, so it will be less severe, and then the patient develops immunity after the infection. As we know, with immunocompromised individuals, the infections are usually much more severe and they'll progress rapidly. With these immunocompromised or suppressed patients, they can also be infected by opportunistic pathogens or normal flora, whereas immunocompetent are usually infected with those primary pathogens that have a higher virulence. Age is an important risk factor that goes hand in hand with the immune status of a patient. Infants and older or geriatric adults are more susceptible to certain respiratory infections, and this is a result of functional immunodeficiency due to age. Infants are more susceptible to infection as a result of underdeveloped immune systems, whereas the geriatric population is more susceptible as a result of declining immune system. In order to determine the significance of a culture isolate, the following factors must be considered: the source of the specimen, the age of the patient, the immunologic status, and the clinical setting of the patient. The isolation of a potential pathogen may represent colonization of the upper respiratory tract or life-threatening disease. Isolation of non-pathogenic organisms that may be a part of normal flora of the upper respiratory tract may be an indication of disease if found in an unusual location or in a patient with decreased defenses against infection. In addition to the factor of age affecting a patient's inclination for infection, reduced clearance of secretions or obstruction of an area in the upper or lower respiratory tract can predispose patients to an infection and can on occasion seriously compromise respiratory tract function. Mechanical clearance is an important defense mechanism in limiting the number of potential pathogens and in the associated inflammatory response. Decreased clearance of respiratory secretions may be a result of immature anatomic development, so it would be purely structural, transient reduction in mucociliary mechanism, obstruction by a foreign body, disease that alters normal respiratory tract anatomy, or alterations in the viscosity of mucus. Another way in which respiratory tract obstruction can be a factor in infectious disease involves compromise of breathing. So this obstruction is a consequence of the infection in which the anatomy of the area determines the urgency with which treatment needs to be initiated. An example in which airway obstruction occurs as a result of infection is in acute epiglottitis with Haemophilus influenza. So this can cause a life-threatening upper airway obstruction, and it's considered a medical emergency, and this occurs in non-immune persons. Other infections with Haemophilus influenza are not necessarily life-threatening and can be treated more deliberately. Awareness of the patterns of respiratory tract infections at different times of the year are important for efficient use of diagnostic microbiology resources. So seasonal patterns dictate the likelihood of infection, whether you're looking at a viral respiratory tract infection or mycoplasma pneumonia associated or bacterial. So with viral infections, these are usually increased in the fall and winter, such as seen with the flu. Mycoplasma pneumonia, as we've discussed previously, has no seasonality. And since viral and secondary infections are decreased in the summer, Mycoplasma pneumonia would typically be the causative agent of respiratory tract infections in the summer months. With respiratory infections, antibiotic therapy sometimes needs to be administered before culture results are taken or available. Seriously ill patients with pneumonia or patients with difficult to reach infections may need to be treated empirically. So when empiric antimicrobial therapy is needed, it's important to have working knowledge of the organisms most likely to cause the type of infections observed and of the antimicrobial agents most likely to be effective. The microbiology lab can provide preliminary data on the possible identity of a pathogen based on gram staining results and preliminary biochemical studies. So treatment can be initiated sooner, but periodic reviews of antimicrobial susceptibility patterns are published by clinical microbiology services to facilitate the decision-making process for these empiric therapies. The last topic we'll discuss in the general concepts of respiratory tract infections are virulence factors. So we'll look at these briefly before we jump into the actual respiratory tract infections. So we've seen that various organisms have differing virulence factors, and the disease-producing capability of an organism is the clinical manifestation of its virulence. Bacteria cause infections, along with other microorganisms, by entering the host, interacting with specific target tissues, evading host's defenses, proliferating, damaging the host, and disseminating or elaborating products that cause systemic disease. Virulence factors involved in disease-producing mechanisms such as adherence, toxin elaboration, and host evasion enable bacteria to complete the process. Attachment of bacterial pathogens to the host tissue is the primary step in an infectious process. Attachment is made possible by adhesins or other microbial surface molecules or organelles that bind the organism to a host surface. As we've seen in previous chapters and also in immunology, specific bacterial adhesins interact with specific cellular receptors. So, for example, as we've seen, streptococci possess fimbriae, which are fine irregular structures composed of M protein and lipoteichoic acid that bind to epithelial cells. Bacteria can also elaborate toxins that produce different pathogenic effects depending on the activity of the toxin and the target cell with which it interacts. So remember, we already looked at enterotoxins that affect the GI tract. So the toxins we'll be looking at with respiratory tract infections include exotoxins, which are those released by living bacterial cells into their surroundings, and endotoxins that are present inside a bacterial cell and are released when the cell disintegrates or when it dies. So going back to the enterotoxin example, toxins can target specific tissue or biological processes. So the enterotoxins, as was mentioned, affect the gastrointestinal tract. The last virulence factor is the organism's ability to evade host defenses. So this enables bacteria to proliferate and cause damage to the host. Certain respiratory pathogens evade host defenses by expressing polysaccharide capsules that prevent phagocytosis by host white blood cells, such as strep pneumonia or Haemophilus influenza. Others are protected from the host immune system by surviving as obligate intracellular parasites. So they're able to hide within the host's cells, such as chlamydia. Other respiratory pathogens are able to cleave host secretory antibody by producing IgA-specific proteases that result in weakening the host's defense mechanisms. So now we're going to jump into the respiratory tract infections. So first we'll look at the upper respiratory tract infections. Pharyngitis is the first upper respiratory tract infection we'll discuss, and it's commonly known as sore throat. This is one of the most common reasons patients visit their primary care physicians, and it results in over 12 million office visits annually in the United States. Most pharyngitis infections occur as a result of group A strep, or strep pyogenes. There are also viral causes of pharyngitis, and this is as a result of the virus that causes the common cold or early influenza infections. Symptoms of group A strep pharyngitis include exudate in the pharynx, painful adenopathy, and a lack of cough. Table 32.1 in your textbook provides a good summary of the upper respiratory tract infections and the causative agents, along with appropriate specimen collection and any pertinent notes. So we'll be discussing each of these in a little more detail on the subsequent slides. So going back to pharyngitis, it typically occurs in the winter to early spring and is transmitted by person-to-person contact. Group A strep, along with other respiratory pathogens that cause pharyngitis, are usually acquired by either contamination of hands and then inoculation into the upper respiratory tract, or by inhalation of droplet aerosols. Clinical manifestations can be difficult to differentiate bacterial versus viral infection, but viral infections tend to present with runny nose, whereas bacterial pharyngitis is just accompanied by the sore throat. Clinical symptoms of bacterial pharyngitis include sore throat or pain and difficulty swallowing. Fever is commonly present, and a thick exudate covering the tonsils. The thick exudate is associated with streptococcal pharyngitis with group A strep, Streptococcus pyogenes. Crinibacterium diphtheria causes a highly contagious and potentially fatal form of bacterial pharyngitis called diphtheria. In this presentation of pharyngitis, a thick pharyngeal membrane is present in the tonsillar area. Crinibacterium diphtheria infection associated with pharyngitis is rare in the United States due to the diphtheria pertussis vaccine. The reasons for the symptoms associated with pharyngitis are not completely understood, but what's known is that the response is primarily due to inflammatory effects of a variety of extracellular bacterial products. The products exhibit various activities including toxicity to different cells and enhancement of the spread of streptococci through infected tissues. Occasional complications can occur as a result of pharyngitis, particularly with group A strep. These include sinusitis, otitis media, pneumonia, soft tissue abscesses, acute rheumatic fever, which results in damage to heart valves, and acute glomerular nephritis. Laboratory testing for pharyngitis is primarily done to differentiate between viral and bacterial infection. In addition, laboratory testing can be done to detect uncommon causes of bacterial pharyngitis. Throat cultures for group A strep are diagnostic, and they are the gold standard that have a sensitivity of 90 to 95%. So when collecting pharyngeal samples for strep throat culture, it's important to swab the tonsillar area only, swabbing both areas as well as the posterior pharynx. And if any tonsillar exudate is seen, it should be swabbed specifically. But when collecting the sample, the tongue and oral structures, such as the teeth or the sides of the mouth, should be avoided to minimize contamination. As mentioned before, culture is the gold standard for laboratory diagnosis of bacterial pharyngitis. Sheep blood agar is what's most commonly used for identifying group A strep, Strep pyogenes. Rapid antigen detection tests can be used at the point of care setting, which employ enzyme immunoassay methods to identify antigens of group A strep. These tests have excellent specificity and can be used to treat positive test results. However, they have variable sensitivity in children, so it's important to send a confirmatory culture for negative rapid antigen detection tests. In adults, follow-up culture generally isn't needed given the lower incidence of pharyngitis. Serologic testing is not useful for diagnosis of acute group A strep infection, but it's helpful in confirming recent streptococcal infection cases of suspected post-streptococcal acute glomerulonephritis. Treatment of pharyngitis varies depending on the causative agent. With viral pharyngitis, treatment is supportive, with the exception of influenza, for which specific antiviral agents are available. Most cases of group A strep bacterial pharyngitis are self-limiting, and symptoms resolve within 3 to 4 days, even without antimicrobial therapy. For patients in which antimicrobial therapy is indicated, the drugs of choice include penicillin or amoxicillin. Alternative drug treatment for patients who are allergic to penicillin include macrolides, clindamycin, or first-generation cephalosporins. Antibiotic therapy has been shown to shorten the duration of symptoms and in some cases the severity. So now we'll move to the next presentation of upper respiratory tract infection, and that's sinusitis. Other terms for sinusitis include infectious sinusitis or rhinosinusitis, and this is a common inflammatory reaction of the nose and paranasal sinuses. This chapter focuses on acute sinusitis, which is usually infectious in origin rather than chronic sinusitis, which can have a diverse series of causes. Sinusitis primarily occurs in winter and spring months. And this presentation of disease is less common in children than in adults because of the incomplete development of most of the paranasal sinuses until adolescence. Viruses are the most common cause of acute sinusitis, including rhinovirus, coronavirus, parainfluenza virus, adenovirus, and influenza virus. Strep pneumonia and Haemophilus influenza are the bacterial pathogens that have historically been identified as the most common causes of community-acquired infections in adults and children. Strep pyogenes, Staph aureus, and Moraxella catarrhalis account for most of the remaining infections. In hospital-acquired infections, Staph aureus and gram-negative bacilli have been recovered more frequently. Acute fungal sinusitis is uncommon in patients who are immunocompetent, but it does occur in immunosuppressed patients treated with either cytotoxic or immunosuppressive medications, or in patients with uncontrolled diabetes. The sinuses normally undergo a continuous cleansing process through the action of the ciliated epithelial cells. So these cells move the mucus layer lining the areas toward the sinus, the opening of the sinuses, into the nasopharynx, and it normally clears the sinuses of bacteria from the adjacent nasopharynx. In acute rhinosinusitis, as a result of infection, mucosal swelling can cause partial or complete obstruction of the sinus, interrupting the flow of secretions and predisposing bacterial overgrowth in the obstructive sinuses. Although this inflammation and swelling can be as a result of an infection, it can also be a result of an allergic cause. Non-infectious obstructions aside from bacteria can cause similar problems such as foreign bodies, including nasotracheal tubes, tumors, and congenital structure abnormalities of the nasopharynx. Common symptoms of acute sinusitis in adults include facial pain or pressure and purulent nasal discharge that can also be accompanied by some non-specific symptoms such as cough, headache, and low-grade fever. It's often difficult to differentiate patients with viral sinusitis clinically from those with bacterial infection. And this issue contributes significantly to the inappropriate prescription of antimicrobial agents for a condition that is largely viral. There are 3 criteria for diagnosis of bacterial sinusitis according to the IDSA, the Infectious Disease Society of America. The patient must experience persistent symptoms without improvement for more than 10 days. Severe symptoms must be present for 3 to 4 days at the beginning of the illness, and symptoms in these initial stages include high fever, purulent discharge, and facial pain. An initial improvement should be observed, followed by a subsequent worsening of symptoms. These figures give an example of detecting sinusitis using CT scans. So imaging with either radiography or CT scanning is not recommended for diagnosis of uncomplicated cases of sinusitis because the abnormalities seen are nonspecific. But in this example, you can see the difference in the left image, which is a normal, showing the sinus tracts being normal in size, and on the right is an image showing sinusitis. So here you can see the difference in the thickening of the linings of the maxillary sinuses compared to this normal image, and that represents the purulence and mucosal thickening within the sinuses as a result of these infections. Complications associated with acute sinusitis include orbital cellulitis. So the patient presents with protrusion of the eye, or they may experience limitation of ocular movements. Osteomyelitis can occur, in which the bone becomes infected, and these infections reach the bone by traveling through the bloodstream or spreading from nearby tissue. A presentation of osteomyelitis is known as Pott's puffy tumor, in which the frontal bone then progresses to an infection and an abscess. Other complications include meningitis, brain abscesses, and cavernous sinus thrombosis. So this is the formation of a blood clot within the cavernous sinus. The cause is usually from a spreading infection in the nose, sinuses, ears, or teeth. The gold standard for diagnosis of sinus infection is direct sinus puncture and aspiration, but this is invasive and painful, and it's not appropriate for routine medical practice. Given knowledge available of the common etiologic pathogens, it's usually unnecessary. There are certain situations in which the sinus aspiculture should be taken, such as if there's a suspicion of intracranial extension of the infection, if empiric antimicrobial therapy has failed, or if the patient is severely ill or immunocompromised. If this type of sample is obtained, it should be inoculated onto culture media such as sheep blood agar, chocolate, and MacConkey agars, and these are the media that are routinely used to isolate respiratory pathogens. Treatment of bacterial sinusitis varies based on the causative agent, whereas no treatment is indicated in viral sinusitis. Typically, with viral sinusitis, symptoms spontaneously resolve within 1 to 2 weeks. With bacterial sinusitis, an example of a treatment option is amoxicillin clavulanate for Streptococcus pneumonia sinusitis, and this could be indicated for both adults and children if there's the absence of risk factors for antimicrobial resistance in the particular population. The next upper respiratory tract infection we'll discuss is acute otitis media, or AOM. So this is infection of the middle ear, and it's the most common bacterial infection in children between 3 and 24 months of age. Most children have had at least one episode of acute otitis media by 3 years of age. Risk factors for this type of infection include a history of ear infection, attendance at daycare or nursery settings, a family predisposition for ear infection, exposure to passive tobacco smoke, nasopharyngeal colonization with otopathogens, and the presence of anatomic nasopharyngeal disorders. Acute otitis media can progress in a similar fashion to sinusitis, in which viral infection plays a role in the pathogenesis of the presentation. Viral infection oftentimes precedes bacterial infection in many cases. There's numerous viruses that can cause acute otitis media, and these include adenoviruses, rhinoviruses, coronaviruses, respiratory syncytial virus or RSV, influenza, human bocaviruses, among others. The bacterial causes of typical cases of acute otitis media have been clearly defined by cultures of infected middle ear specimens obtained by direct aspiration from the area, and Streptococcus pneumonia accounts for a significant proportion of the isolates. Other organisms responsible for this type of infection include Haemophilus influenza, Moraxella catarrhalis, and Group A strep and Staphylococcus aureus have also been isolated, but less commonly. As mentioned before, viral upper respiratory tract infections often precede or occur concurrently with most cases of acute otitis media. Infection is established when there is impairment of the normal host defense and drainage mechanisms. The middle ear and eustachian tube, the canal that links the middle ear to the nasopharynx, are lined with ciliated epithelium and mucus-secreting cells, and these cells are what function to prevent infection through clearance of contaminating microorganisms. Infections in which purulent exudates are present can cause fluid buildup in the middle ear, and if this is prolonged, it can affect hearing long term. The diagnosis of acute otitis media is based on signs, symptoms, and direct examination of the tympanic membrane of the ear. Ear pain is a classic symptom, and early signs and symptoms may not be localized, especially in young children. In these cases, fever and irritability may be the only signs of illness. In older children, tugging at the involved ear may be noticed during or at the end of an upper respiratory tract infection. Changes in hearing and late in the course of infection, drainage of purulent secretions from the ear canal can be associated with perforation of the tympanic membrane. Progression of acute otitis media can damage the tympanic membrane, resulting in perforation, which is an associated complication. Chronic middle ear infections can be an issue in younger children due to subsequent hearing loss that can have adverse effects on speech development and education. This is less of a consequence in adults because their speech has already been developed. Severe supportive complications of acute otitis media are rare. Because of the invasiveness of direct aspiration of fluid from the middle ear, and because the predominant pathogens are known, obtaining specimens for culture before initiating therapy is neither recommended nor necessary in most cases. Culture may be indicated if an unusual or drug-resistant organism is suspected, or if the patient fails to respond to the empiric antibiotic therapy. It is important to treat children older than 6 months with severe otitis media. Antimicrobial treatment is recommended with severe otitis media in which a temperature is greater than or equal to 102 degrees Fahrenheit or 39 degrees Celsius, in which the patient experiences moderate or severe pain for at least 48 hours. Children aged 6 to 23 months with bilateral non-severe acute otitis media also should be treated. If treatment is indicated, the initial drug of choice is amoxicillin if the patient has not received the drug within the prior 30 days. Failure to respond to this regimen may indicate a resistant organism, such as a penicillin-resistant pneumococci or beta-lactamase-producing Haemophilus or Moraxella, in which case alternative antimicrobials should be used. Epiglottitis is an upper respiratory tract infection of concern due to the rapid progression and obstruction of the airway. So the epiglottis is a cartilage structure positioned at the anterior aspect at the opening of the trachea, and its function is to protect the airway from aspiration of secretions and food during swallowing. Epiglottitis, also known as supraglottitis in adults, can rapidly progress an infection of the epiglottis and adjacent soft tissue in the upper airway. This is a life-threatening emergency if a patient presents with this infection. Historically, epiglottitis was primarily a disease of children aged 2 to 7, but with the emergence of the vaccine for Haemophilus influenza type B, there was a decline in the incidence in children. Now, most cases have been seen in adults, and it's an uncommon occurrence in clinical practice. Although it is uncommon, the potentially life-threatening nature of this infection warrants clinicians being familiar with this presentation. Before the widespread vaccination, Haemophilus influenza B was responsible for most pediatric cases. Today, there are still documented cases of HIB causing epiglottitis even in vaccinated individuals, but most cases are caused by other pathogens, including group A strep, Streptococcus pneumonia, Staphylococci, including MRSA, Haemophilus parainfluenza, and Klebsiella. In addition, clinical presentation can be a result of non-infectious causes such as chemical and thermal irritants. The soft tissue of the epiglottis and its surrounding structures are susceptible to accumulation of fluid during the inflammatory process caused by infection. Combined with the critical location of the epiglottis at the opening of the trachea, this creates danger of partial or complete airway obstruction as the disease progresses. It's common in adults to have involvement of other structures in the supraglottic region, including the vacuola, arytoids, aryepiglottic folds, and that's why this has also been termed supraglottitis, often in adults. Symptoms of epiglottitis include severe pharyngitis, sore throat, and severe pain on swallowing. And again, this is a life-threatening infection and disease presentation, so treatment should begin immediately. The most important complication of epiglottitis is respiratory compromise that progresses to respiratory failure because of airway obstruction from edema. Other potential complications include the development of epiglottic abscesses, necrotizing epiglottitis, pneumonia, and in patients who are bacteremic, meningitis, and septic shock. Direct swab cultures from the area of the epiglottis are useful for establishing the causative diagnosis, but they should be taken only when the airway is secure. A direct smear of the epiglottic exudates for microscopic exam may reveal numerous white blood cells and pleomorphic gram-negative rods, characteristic of Haemophilus influenza or other gram-negative bacterial pathogens. Blood cultures could also be performed in patients in which epiglottitis is suspected. Enriched media such as chocolate agar should be used when trying to isolate Haemophilus species. This is an example of a gram stain of a sputum exudate with Haemophilus growing. As you can see, indicated by the black arrow, Haemophilus are the very tiny gram-negative rods, or they also appear cocobacilli-like. IV antibiotics such as third-generation cephalosporins or ampicillin sublactam should be administered for patients diagnosed with epiglottitis. Coverage of MRSA should also be added when risk factors exist. If immediate airway securement is not required at the time of initial evaluation, patients should be closely monitored for signs and symptoms of respiratory distress. Additional measures such as intubation or tracheostomy may be done if a patient does progress into respiratory distress. The last upper respiratory tract infection we'll talk about before moving into the lower respiratory tract ones is pertussis. Pertussis is commonly referred to as whooping cough, and it's a highly communicable respiratory illness in susceptible patient populations, and it's transmitted from person to person by aerosolized droplets or direct contact with secretions. Pertussis is more common in infants and young children, and serious complications can be seen in this age group. After the introduction of a pertussis vaccine in the 1940s, the incidence significantly declined by 1970s. However, in recent years, disease incidence has again begun to increase, including large outbreaks in several states with notable infant mortality and increase in cases in adolescent and adult populations, most likely due to waning immunity. Older patients can also exhibit infections with milder manifestations of the illness, and this can go undiagnosed and also allow them to serve as reservoirs for transmission of the infection to susceptible children. Bordetella pertussis and Bordetella parapertussis are the primary pathogens usually associated with pertussis. Bordetella bronchoseptica and Bordetella holmesii have also been associated with similar clinical syndromes. An important differential diagnosis in patients presenting with pertussis-like syndrome is adenovirus infection. Although the pathogenesis of pertussis is not completely understood, numerous studies suggest that the pertussis toxin plays a significant role in the clinical presentation of this infection, because the toxin damages tracheal epithelial cells and impairs immunity. In the initial presentation of pertussis infection, the symptoms are similar to those of a viral upper respiratory tract infection with mild cough, conjunctival infection, and nasal congestion and discharge, and this makes the differential diagnosis difficult for the first 1 to 2 weeks. Fever is uncommon or low grade throughout the course of the illness unless a secondary bacterial infection has occurred. After the 2 to 4 week phase follows the typical manifestation by episodes of coughing, often with multiple coughs during one expiration cycle, and a characteristic whooping sound at the conclusion, and this is caused by forceful inspiration through a narrowed airway. Symptoms are often worse at night, and the final stage may last for several more weeks and compromises a chronic cough. Complications associated with pertussis include pneumonia, which is the most common occurring in infants and young children. It's usually caused by secondary infections with other bacteria. In some cases, pertussis can result in death, and this is generally as a consequence of pneumonia in young unvaccinated children or older patients with underlying comorbidities. Many complications associated with pertussis are a result of severe and forceful coughing episodes that occur, including pneumothorax, or the collapse of the lung, hemorrhaging, nosebleeds, rupture of the diaphragm, umbilical and inguinal hernias, and rectal prolapse. And these are all as a result of the severe coughing. Blood testing included in diagnosis of pertussis include a CBC, which may show lymphocytosis, and this is a reaction to the pertussin toxins. Isolation of Bordetella pertussis in culture from nasopharyngeal secretions is the gold standard for diagnosis and exhibits high specificity. However, culture recovery of Bordetella pertussis can be difficult. Successful isolation of Bordetella pertussis in culture depends on timing. Specimens should be collected early in the course of disease, preferably within the first 2 weeks of onset of the cough, from the posterior nasopharynx, and should be plated directly onto selective media, such as Burdo-Gango or Reagan-Low media, for optimal recovery. If direct inoculation is not possible, transport media such as Reagan-Low media should be used. Remember, we discussed this a while ago, but for Bordetella pertussis isolation, the nasopharyngeal swab is the specimen of choice. Because of time delay in obtaining culture results and the difficulties in recovery, culture has largely been replaced by molecular methods such as PCR. Direct fluorescent antibody testing has been used as complementary methods for identifying, but it's not recommended for diagnosis without a positive culture or PCR result because of poor sensitivity and specificity. Serologic testing may be helpful 2 to 12 weeks after the onset of cough when culture and PCR results are more likely to be negative, and it's useful in outbreak investigation. The major treatment option for pertussis is vaccination, which helps prevent the disease. For patients that are infected with Bordetella pertussis or other species resulting in this type of infection, antibiotics administered include erythromycin, clarithromycin, and azithromycin. This antibiotic therapy only helps patients early on in infection, and it also serves as a prophylaxis for contacts of the patient. It's important to note that pertussis is a nationally reportable disease, and cases must be reported to local health departments. So now we'll move on to lower respiratory tract infections. Infections in the lower respiratory tract usually occur when infecting organisms reach the lower airways or pulmonary parenchyma by bypassing the mechanical and other nonspecific barriers of the upper respiratory tract. Infections may result from inhalation of infectious aerosols, aspiration of oral or gastric contents, or spread through the bloodstream. In order for potential pathogens to establish infection in the lower respiratory tract, a series of host defenses need to be overcome. The sequence of events is different for respiratory viruses versus bacterial pathogens. The progression of viral pathogens from the upper to lower respiratory tract is a process that involves spread among adjacent cells and distant inoculation of susceptible cells by aspiration of infectious secretions and by spread through the bloodstream as well. Lung infections by bacterial pathogens usually occur by direct inoculation of organisms through aspiration from the upper respiratory tract. Acute bronchitis is an infection and inflammation of the bronchi without involvement of the lung parenchyma, as in pneumonia. Bronchitis can be viewed as a lower respiratory tract extension of many of the same viral infections that cause seasonal upper respiratory tract infections, and in many cases these syndromes represent a continuum of the same infection. The peak seasons for acute bronchitis are in the winter months, which correlates with the period of peak incidence of the viral respiratory tract infections. Acute bronchiolitis is an infection and inflammation of the smaller bronchioles, and this is the most common lower respiratory tract infection in infants and is most often seen in children younger than 2 years. Any of the respiratory viruses that cause upper respiratory tract infections can cause cough and as a manifestation of acute bronchitis. During seasons when influenza virus is epidemic in the community, the respiratory pathogen is the most common cause of acute bronchitis in the general population. During non-epidemic periods, other respiratory viral pathogens such as rhinovirus, coronavirus, human metapneumovirus, and parainfluenza virus are often identified. Non-viral respiratory tract pathogens include Mycoplasma pneumonia, Chlamydophila pneumonia, and Bordetella pertussis, and these can also produce acute bronchitis. The clinical presentation of these infections may be indistinguishable from that of acute bronchitis caused by viral pathogens. In infants, the predominant cause of bronchiolitis is respiratory syncytial virus. With bronchitis, as noted earlier, evidence almost always exists that a pre-existing or coexisting upper respiratory tract infection is present in patients that have acute bronchitis. The spread of these upper respiratory tract infections to lower airways manifested as acute bronchitis represents infection and damage of the respiratory epithelial cells by the same pathogens. Destruction of the respiratory epithelium differs with the pathogen causing illness. Viruses such as influenza and adenovirus are highly cytopathic and can cause significant epithelial cell destruction, whereas other viruses cause dysfunction. The inflammatory response, necrotic debris from epithelial cell destruction, bronchospasm, and edema of the lower respiratory tract contributes to the airway abnormalities and symptoms in these types of infections. The potential for airway obstruction, air trapping, and increased airway resistance is especially important in bronchiolitis in infants. Patients with acute bronchitis often begin their illness with a syndrome typical of a viral upper respiratory tract infection, including runny nose and cough. Systemic symptoms such as diffuse myalgias, low-grade fever, and fatigue associated with viremic illness may also be seen early in the course of infection. The hallmark symptom of acute bronchitis is a cough that can persist for as long as 6 weeks. Symptoms of acute bronchitis generally last an average of 7 to 10 days, but they can persist for several weeks, especially in immunosuppressed patients. It's important to note that chronic bronchitis can occur, and this is classified with a patient that has 3 months of symptoms for at least 2 years, and this is usually linked to long-term cigarette smoking, whereas acute infection is from an infectious process. Acute bronchiolitis is the infectious process of infants, and again, this is usually as a result of RSV infection, and symptoms include wheezing, respiratory distress, and air trapping. Complications in some patients with acute viral bronchitis is the development of secondary bacterial infections, either bronchitis or pneumonia. These secondary bacterial infections of the lower respiratory tract are usually due to common pathogens found in community-acquired pneumonia, such as Streptococcus pneumonia or Haemophilus influenza. Other bacterial pathogens may also be involved in select patient populations, such as gram-negative rods or Moraxella catarrhalis. Severe bronchiolitis is more common in younger, especially premature infants. Long-term consequences of acute bronchitis and bronchiolitis are debatable, and several epidemiologic studies suggest an association between acute viral infections of the lower respiratory tract and subsequent asthma. Because most bronchitis infections are caused by viruses with no available directed therapy, diagnostic testing is not indicated in uncomplicated cases that follow an expected self-limiting course, unless there's some epidemiologic reason for testing. If patients, however, have a secondary bacterial bronchitis, pertussis is suspected, or pneumonia is a concern, diagnostic testing may be useful in guiding therapy. Secondary infections usually require obtaining a sputum, which can be obtained easily most times. Respiratory syncytial virus PCR testing may be done for infection control purposes during outbreaks. Again, since acute bronchitis is more commonly caused by viral infections, they should not be treated with antimicrobial therapy in otherwise healthy individuals who don't have a concurrent pneumonia infection. We'll be moving to discussing acute pneumonia next, but just a note on the handouts that were posted for you in Moodle. There are several slides that discuss influenza, but as with the other chapters we've been discussing, we're primarily looking at bacterial pathogens right now. So you won't be expected to know the material regarding influenza for this section of your microbiology course, and we'll discuss it further in the virology section. So now we'll skip over those slides discussing influenza, and we'll start looking at acute pneumonia. So in regards to acute pneumonia, distinguishing between this presentation and acute bronchitis may be subtle, and the distinction depends on the extent of involvement of the lower respiratory tract with the infectious process. So by definition, patients who have bronchitis do not exhibit the physical, radiographic, and pathologic findings of pulmonary parenchymal involvement outside of the airways. This type of lung tissue involvement with the infectious process defines pneumonia. So pneumonia can be divided into diagnostic categories based on the clinical setting, presentation of the illness, exposure to pathogens, and age and type of the individual infected. It's important to use these categories and this strategy to make presumptive determination of the cause of pneumonia, because there's so many possible pathogens that can cause this type of infection. So table 32.3 in the textbook provides the most common pathogens of the lower respiratory tract, and it's divided by age. So on the subsequent slides, we'll be looking at community-acquired pneumonia, abbreviated as CAP, also nosocomial pneumonia. And from this table, you can see that pneumonia occurs in very young and very old patients, but the causative agents most likely to cause these pulmonary infections in the two groups vary. So in infants and children, respiratory viruses cause most pneumonias, whereas in older adults, bacterial pathogens are more likely to be involved in infection. Community-acquired pneumonia is defined as the onset of symptoms in the community or within the first 2 days after admission to the hospital. This type of pneumonia is one of the most common infections encountered in clinical practice and the leading cause of death from infection for persons over 65 years old. There has been a decrease in invasive pneumococcal disease as a result of vaccination against strep pneumonia, which is one of the most common bacterial pathogens in children and in adults. But despite advances in diagnostics and therapeutic treatments in recent years, mortality rates have remained unacceptably high, and this may be as a result of adults living to older ages, various treatments that suppress the immune system, such as chemotherapy, and the higher incidence of cancers or immunosuppression overall. A large proportion of community-acquired pneumonia in children can be attributed to the same viral pathogens that cause upper respiratory tract infections in the community during the winter months. These viruses can result in lower respiratory tract disease as well, including bronchiolitis, croup, and pneumonia. RSV is the most commonly identified cause of viral pneumonias in children, especially in infants in most communities. Influenza virus is the most common virus isolated in adult pneumonia patients and can cause primary viral pneumonia or be associated with a subsequent bacterial superinfection, including infections with strep pneumonia and Staph aureus. In adult patients presenting with pneumonia, Haemophilus influenza and atypical pathogens such as Mycoplasma pneumonia, Chlamydophila pneumonia, and Legionella should also be considered as potential causative agents. And these are categorized as atypical pneumonia. In most cases, bacteria from the oropharynx or the GI tract gain access to the lower respiratory airways through aspiration. So normally the defense mechanisms of the lung, including ciliated epithelial cells and innate immune system phagocytic cells, can clear the aspirated bacteria before infection is established. Infection of the lower respiratory tract can develop if the bacteria involved are particularly virulent, the inoculum of inhaled microorganisms is high, or the immune system has been suppressed or compromised. The usual onset of non-bacterial pneumonia in children is indistinguishable from that of other viral upper respiratory tract infections. The clinical presentation of typical bacterial community-acquired pneumonia in adults differs with the age and immunologic status of the host. Most patients with bacterial pneumonia have a relatively sudden onset of fever associated with chills. They experience productive cough of purulent sputum that may be blood-tinged. Chest exam and radiographs typically show a localized area of lung involvement described as lobar consolidation. Routine laboratory studies will usually show an increased white blood cell count and neutrophilia with an increased percentage of immature forms of granulocytes, known as a left shift. Here's an example of chest radiographs. On the left is a chest radiograph of a patient before they've developed pneumonia, or a healthy individual. So here you can see there's clear areas on both sides of the radiograph. On the right is a patient who's developed pneumonia. So here you can see the condensation of the upper right lobe. And this can be seen by the opaque area, which contrasts with the normal black area in which air is present in the remainder of the lung. Common complications of community-acquired pneumonia include parapneumonic effusions, and this occurs when accumulation of fluid in the pleural space caused by inflammation from pharyngeal lung infection is seen. Parapneumonic effusions occur frequently in the setting of community-acquired pneumonia, so those that are less severe resolve with antimicrobial therapy. However, if appropriate therapy is delayed, the patients risk becoming overly infected, resulting in formation of empyemas, which are collections of purulent fluid in the pleural space that require drainage. Other complications associated with community-acquired pneumonia are respiratory failure, including the need for mechanical ventilation. Respiratory failure can progress to acute respiratory distress syndrome or septic shock with multisystem organ failure. In some cases of atypical pneumonia, encephalitis may occur. For patients with mild disease who are treated as outpatients, microbiology diagnostic testing is generally not performed, but patients with more severe disease who are hospitalized may meet criteria for cultures of blood and sputum. Remember, we discussed the criteria for sputum cultures, and this can sometimes be problematic because as the sputum is expectorated from the lower airways, it has to pass through the upper airway, and this is colonized with many normal biota, which can interfere with isolation of true pathogens and make interpretation of results difficult. So it's recommended that these sputum cultures be screened to ensure that they have no more than 10 squamous epithelial cells and at least 25 polymorphonuclear cells per low power field to ensure that the sample is acceptable. Aside from culturing these specimens for laboratory diagnosis, molecular testing has also been utilized, such as PCR, to identify pathogens in cases in which cultures are negative and to provide rapid test results to allow better targeting of therapy. In some cases, antigen testing may also be indicated, for example with Legionella pneumophilia, in which urine antigen testing is done. So here's an example of a gram-stained sputum smear, and this is an acceptable sample, although it's scanned in closely. So here you see there's many white blood cells present. In this field, there's no epithelial cells, and there's many gram-positive cocci and gram-positive diplococci. So here you see some forms are almost cocobacilli-like, but knowing that this is a sputum, although the textbook doesn't specify, this is probably a strep pneumonia based off the characteristic gram stain. Here's an example of an expectorated sputum that is unacceptable. So here you see there's many epithelial cells, and there's no white blood cells present, and a lot of contaminating bacteria that is most likely normal flora. This aspirated sputum is an acceptable sample. Although there are no white blood cells present, there are also no epithelial cells present. There's no organisms present either in this smear, but you can see these specialized cells and the pink background indicate that it's local materials from the surface of the tracheobronchial tree. So this smear confirms that the sputum was sampled and that there's no suspicion for infection and no evidence of contamination. Other more invasive methods of obtaining lower respiratory tract samples include tracheal needle aspiration, which is rarely used because of its invasive nature, risk of complications, and poor acceptability by patients. Bronchoscopic methods are more commonly used for patients who require mechanical ventilation, but can also be used in the cases of refractory or recurrent pneumonia when the success of empiric therapy is in doubt. Cultures obtained by these more invasive methods also don't have 100% specificity because upper airway contamination can still occur during specimen collection. In addition to issues of specificity in identifying a true pathogen, sensitivity is also an issue for any of the culture methods. Common pathogens such as strep pneumonia are intrinsically difficult to culture, and pretreatment with antibiotics can render cultures falsely negative. Legionella cases also can be challenging to diagnose because culture of these organisms from sputum or bronchial aspirate is often difficult, requiring special media. In addition, Legionella do not stain well with gram stain. As mentioned previously, molecular diagnostic tools such as PCR have been used to identify pathogens in cases in which cultures are negative and or to provide rapid test results to allow better targeting of therapy. Many times, these PCR assays are routinely used as a panel or a battery of the most common respiratory pathogens. Sensitivities have significantly improved over time, and this is why molecular is more widely used for respiratory panels. Although the tests are sensitive, specificity problems can exist, so clinicians need to interpret results in context. So they need to make sure they're evaluating whether a positive PCR is a true pathogen or if the patient is asymptomatically colonized. Pneumococcal pneumonia caused by strep pneumonia is a bacterial causative agent of community-acquired pneumonia of concern. Laboratory testing includes culture in which alpha hemolytic colonies are produced on blood agar. Biochemical tests such as biosolubility and obtotient sensitivity can distinguish strep pneumonia from other streptococci. Cultures from blood and pleural fluid can indicate the cause of pneumonia. Many adults with pneumococcal pneumonia also will have positive blood cultures, but this is less common in children. So here's another example of a gram stain smear of a respiratory pathogen, and this is strep pneumonia. This is obtained from a blood culture sample. So here you can see the strep in chains, gram-positive cocci in chains, and then there's several that you can see appearing as diplococci. In terms of treatment for community-acquired pneumonia, initial decisions about management need to be made whether the patient should be hospitalized or can be treated on an outpatient basis. There's multiple severity of illness scores proposed by different guidelines, and these have been subsequently validated for use in adults. Two of the most common used indices are the CURB 65 criteria and the Pneumonia Severity Index. These criteria are often used in addition to an assessment of each patient's resources and clinical situation to determine whether admission is warranted. The likelihood of drug-resistant pneumococcal infection must also be considered to determine appropriate antimicrobial therapy. For adults, macrolide antibiotics may be used in outpatients with community-acquired pneumonia who have no other risk factors. In the case of comorbidities or recent antimicrobial use, a respiratory fluoroquinolone alone or a beta-lactam antibiotic plus a macrolide is recommended. This table provides a brief summary of different scenarios in which patients are treated for community-acquired pneumonia. So the first scenario is an ICU patient with suspected Pseudomonas or community-acquired MRSA. So this patient would be treated empirically initially, and then the therapy would be modified to cover whichever pathogen was isolated. So for example, if MRSA was isolated, then the patient might be administered vancomycin, linezolid, or clindamycin. With the second scenario, in which a young child is diagnosed with pneumonia, if the infection is viral in nature, no antibiotic therapy is recommended. Young children with pneumonia in which antibiotic therapy is warranted usually would be administered amoxicillin or ampicillin or third-generation cephalosporins. And then the last scenario, in which a patient is diagnosed with either influenza A or B, antiviral therapy should be started and no antimicrobial therapy unless the patient has a secondary bacterial infection. So now the next type of pneumonia we'll talk about are the hospital or healthcare acquired pneumonias, and then also ventilator associated pneumonias. So the hospital acquired pneumonia is one in which the patient acquires infection 48 hours or more after hospital admission, and this category is not associated with mechanical ventilation. VAP, or ventilator-associated pneumonia, is defined as a pneumonia episode diagnosed at least 48 hours after airway intubation and initiation of mechanical ventilation. The term nosocomial has been addressed, but just so you are clear, that involves originating in a hospital, such as a nosocomial infection is when a patient obtains during a hospitalization. Ventilator-associated pneumonia is estimated to occur in approximately 10 to 20% of patients who require mechanical ventilation for longer than 48 hours. It was once thought that early onset VAP, occurring within 5 days of intubation, was more likely caused by antibiotic-sensitive bacteria, and late onset, occurring more than 5 days, was more likely to be caused by multi-drug resistant. But it's not really clear, this distinction, and there's some studies that show isolated organisms at a similar rate. So typically, there's a greater risk of infection with multi-drug resistant pathogens in a hospital setting. The pathogens associated with nosocomial pneumonia differ from those of community-acquired pneumonia. Microaspiration of upper airway secretions is the most common route of pathogen entry into the lower respiratory tract. The cause of nosocomial pneumonia depends largely on the type of organisms colonizing the oropharynx and possibly the GI tract. So patients with nosocomial pneumonia are at a greater risk for colonization and infection with a wider spectrum of multi-drug resistant bacterial pathogens. Intubation greatly increases the risk of developing nosocomial pneumonia by bypassing the normal mechanical defenses provided by the glottis and cough reflex. Nasogastric intubation also increases the risk of aspiration resulting from interference with glottic function and increased reflux of gastric secretions into the oropharynx. This figure shows a gram stain of a gram-negative rod in a tracheal aspirate. So here you can see this organism is intracellular within the white blood cell, and these are more common pathogens in nosocomial pneumonia. Diagnosing nosocomial pneumonias is often challenging since there are a number of non-infectious processes that can affect the lungs and also cause many of the same clinical signs and symptoms and chest radiograph findings seen with pneumonia. A generally agreed upon definition uses clinical criteria that a new or persistent infiltrate on chest imaging is accompanied by any of the following: fever, elevated or depressed white blood cell count, increased oxygen requirements, and production of purulent sputum. With that, these findings are relatively nonspecific, and this is what makes it difficult in diagnosing. Complications of this type of pneumonia include rapidly progressing pneumonia in which the patient requires ventilator assistance. Overwhelming infection or lung injury can result in respiratory failure, acute respiratory distress syndrome. Bacteremia can also be present, particularly with gram-negative organisms, and then septic shock. Many of the same principles for microbiologic diagnosis apply to nosocomial pneumonia as those discussed for the community-acquired pneumonia. Expectorated sputum, bronchoalveolar lavage, or endotracheal aspirate are acceptable samples, but they must be quality specimens that are not contaminated from the oropharynx. Routine culture media should be inoculated, including sheep blood agar, McConkey plates, and chocolate agar. And if no contamination is present, anaerobic cultures may also be completed, if requested by the clinician. Early implementation of appropriate therapy has been shown to decrease mortality in patients with hospital-acquired pneumonia. So broad-spectrum antimicrobial therapy should be started empirically and then modified based on culture data and clinical response. Typically, empiric therapy should be directed against virulent and drug-resistant strains such as MRSA, Enterobacteriaceae, Pseudomonas, and Acinetobacter. When evaluating therapy for the patient, it's important to consider the institution's antibiogram, which are the typical susceptibility patterns for organisms isolated, and the patient's previous resistance patterns. In terms of ventilator-associated pneumonias, there have been significant focus on measures to prevent this type of nosocomial pneumonia. VAP bundles have been developed and are popular in many hospitals to target reduction in the rate of VAP, with VAP being one of the key performance indicators that many institutions analyze. So these bundles include measures such as elevating the head of the bed to prevent aspiration, weaning sedation daily to decrease time on the ventilator, preventing complete suppression of protective cough reflex, oral care to decrease oral colonization with potential pathogens, and the use of minimum positive end expiratory pressure. Although these interventions have been shown to decrease the number of VAPs, many have not been shown to improve overall patient outcomes. So the next lower respiratory tract infection we'll discuss is empyema. And we already saw that briefly, being involved with a complication of community-acquired pneumonia. So, to reiterate the definition, empyema is a collection of purulent fluid in the pleural cavity. And again, most occur in association with a concurrent acute community-acquired pneumonia. They can also occur with healthcare-associated processes as well. Risk factors for developing empyema include advanced age or very young age, patients of the male gender, debilitation, comorbid diseases, and longer duration of symptoms prior to receiving appropriate therapy. Increases in the incidence of empyema in children have been noted after seasonal and pandemic influenza epidemics. And rates of empyema in children seem to be increasing despite an overall decrease in hospitalizations for pneumonia. The most common causative agent of empyema in children is Streptococcus pneumonia. After the introduction of the vaccination, rates of invasive pneumococcal disease have decreased significantly, but a number of studies have shown an increase in empyema incidence, including those secondary to strep pneumonia infection in pediatric and adult populations. Many of these pneumococcal empyemas were non-PCV7 serotypes, which is the strain of which the vaccine is made. Other common causes in patients with community-acquired pneumonia include Strep pyogenes, other streptococcal species, and Staph aureus. As we also saw with the hospital-acquired and ventilator-associated pneumonias, aerobic gram-negative rods are also a major cause of empyemas in these hospitalized patients. Empyema is usually a consequence of extension of infection directly from the underlying lung to the pleural space. So again, most empyemas occur in patients with community-acquired infections for whom there's been a delay in treatment. Empyema may complicate chest surgery or chest trauma and limit the motion and function of the lung. The organisms that cause this infection are typically resistant to many antimicrobials. Aside from infection being caused by these resistant organisms, the area in which the infection occurs is also a cause of making it difficult for antimicrobial therapy to reach the organisms, since there's a limitation of blood supply to the area and a low pH. The clinical presentation of a patient with empyema is often indistinguishable from the disease of the underlying lung. Patients can have chest pain on the affected side, fever, chills, and night sweats, and sepsis may develop. The main consequence or complication of empyema is persistence of infection. If it's not drained and treated with appropriate antibiotics, the infection causing empyema might be difficult to eliminate. This, in effect, can result in sepsis and long-term damage to the lungs, in which a thick capsule forms and reduces lung function. A thoracentesis, in which removal of pleural fluid is performed through a needle or tube, is done to obtain sampling of pleural fluid space. These specimens should be sent for culture, and any remainder should be held for any special studies if needed. The main treatment options for empyema include drainage of the infected fluid concurrent with appropriate antimicrobial therapy. Again, before we discuss aspiration pneumonia, the next set of slides cover tuberculosis and chronic pneumonias. So these, again, are organisms that we're going to discuss later on in the mycobacteria portion of the course. So again, they're available in your notes, but you won't be responsible for this material on the upcoming exam. So now with aspiration pneumonia, this occurs when gastric or oropharyngeal contents are inhaled into the larynx or lower respiratory tract. And a number of syndromes can result, including aspiration pneumonitis, a non-infectious chemical injury, aspiration pneumonia, a lower respiratory tract infection caused by inhalation of bacteria colonizing the oropharyngeal, or in some cases, gastric secretions. So these two syndromes are often difficult to differentiate clinically. Community-acquired and ventilator-associated pneumonias also likely will result from microaspiration of bacteria colonizing the oropharynx. So aspiration pneumonia discussed in this section will focus on the pneumonias felt to be due to macroaspiration events. Aspiration pneumonia occurs in children and adults and is more common in hospitalized patients, those with dysphagia, or those who have reduced levels of alertness for a variety of reasons, including alcohol or sedative use. Other risk factors include poor oral hygiene and periodontal disease, esophageal dysmotility disorders, enteral feeding, and the use of gastric acid blocking medications. Patients with community-acquired aspiration pneumonia are more likely to have infections with strep pneumonia, Haemophilus influenza, Staphylococci, and Enterobacteriaceae, whereas gram-negative pathogens including Pseudomonas aeruginosa are isolated more commonly from patients with nosocomial aspiration pneumonia. Anaerobic pathogens are isolated infrequently, but they may play a role in patients with prolonged illness and development of complications. The possible anaerobic causes include Bacteroides, Prevotella, Peptostreptococci, and Fusobacterium. Aspiration pneumonia follows the abnormal entry of upper airway secretions colonized with bacteria into the lower respiratory tract. The likelihood of developing infectious pneumonia after aspiration depends on the frequency of aspiration, the quality and quantity of material aspirated, and the patient's host defenses. Patients who are immunosuppressed by underlying disease and/or chemotherapy and patients with altered lung defenses are at increased risk for development of infection after aspiration of a bacterial inoculum. Chemical aspiration pneumonitis is thought to occur when inhaled gastric acid causes injury, resulting in severe inflammatory response and increased permeability of the tissue. Most of these cases are thought to be sterile, but secondary bacterial superinfections can occur. Aspiration pneumonia and aspiration pneumonitis cannot be distinguished based on symptoms alone, but they are categorized as different disease presentations. With aspiration pneumonitis, it classically presents with a witnessed aspiration event and sudden increased coughing, wheezing, hypoxia, and possible progression to respiratory failure. These patients may have fever and significant infiltrates on chest radiography, despite having no active infectious process. Aspiration pneumonia typically presents in a more subtle way, in which symptoms may be evident as coughing while patients are eating food or drinking, and the events are often inapparent or called silent. If treatment fails with aspiration pneumonia, it can progress to necrotizing pneumonia and lung abscesses. Patients with lung abscess usually have a long history of illness with more subtle onset of symptoms than patients with common acute bacterial pneumonia. Patients with these lung abscesses are also more likely to have a putrid sputum and to complain of halitosis resulting from the involvement of anaerobic bacteria in the lung abscess infection. Obtaining specimens for diagnosis of causative agents of aspiration pneumonia is similar to the methods described for community-acquired and nosocomial pneumonia. So the major difficulty with differential diagnosis is distinguishing aspiration pneumonitis, which is a non-infectious process, from aspiration pneumonia, which does not warrant therapy. Treatment options include broad-spectrum antibiotics that provide coverage for aerobic and gram-negative organisms. Anaerobic bacteria should also be empirically treated if implicated. The next section of this chapter will discuss our respiratory tract infections in immunocompromised hosts. So, opportunistic pathogens generally will not cause disease in healthy individuals with normal immune function and require impairment of individual host defense mechanisms to cause disease. So, patients who are susceptible to these opportunistic infections are referred to as immunocompromised hosts. The next section in your notes is another one that you will not be responsible for the material for this upcoming exam. So this section discusses patients with HIV, and a lot of the opportunistic pathogens are either fungal or mycobacteria in origin. So we'll be looking at these again later on in the course. The immunocompromised patients we'll be looking at are those who are immunosuppressed due to other states. So, infections in these immunocompromised individuals depend on a variety of factors. So, some of these patients have deficiencies in specific immune system function. They have been exposed to particular agents or other patients that make them more prone to infection. Transplant patients are susceptible immunosuppressed patients. And of course, patients who have developed various cancers. With these patients, it's important that measures are taken to mitigate infection risks. So with some of these patients, antimicrobial prophylaxis is recommended. Patients with compromised immunity are at risk for all of the typical infections an immunocompetent person might acquire, as well as opportunistic pathogens that are not clinically significant in the presence of an intact immune system. These organisms include Staph aureus and Pseudomonas aeruginosa and various fungi, along with different viruses and parasites. In general, immunocompromised individuals may not present with the same symptoms as immunocompetent individuals. Manifestations of infection may be muted or atypical, and infections with encapsulated organisms such as pneumococcal pneumonia are more common and may be more severe than in immunocompetent hosts. Given the frequency of exposure to broad-spectrum antibiotics, long stays in hospitals, and other comorbidities, antibiotic-resistant bacteria, including Enterobacteriaceae, Staphylococcus, and Pseudomonas, are seen more commonly in these hospital-associated cases. So an example of an immunosuppressed patient and clinical manifestations include a patient with leukemia. So this type of patient has reduced granulocytes as a result of chemotherapy, and this damages the immune system and tissues, and then this in effect increases the likelihood of infections in this patient population. Other immunosuppressed patients, such as those hospitalized for long periods of time or ventilator assisted, will often have respiratory infections such as upper respiratory tract and pneumonia infections, and these are often due to drug-resistant pathogens as a result of prolonged treatment. In addition, aside from the bacterial pathogens we're focusing on, immunosuppressed patients are more prone to viral, fungal, and parasitic infections. And again, we'll be discussing these later on in more detail. In terms of laboratory diagnosis for immunosuppressed patients, a similar workup is used as for patients with HIV, but also in many cases immunocompetent hosts. But as has been mentioned before, it's important with both HIV and any immunosuppressed patient to make sure organisms that are typically normal flora or colonizing organisms are worked up, particularly if they predominate in a culture. Treatment options for infections of immunosuppressed individuals is identical to that of similar infections in immunocompetent patients in most cases, but there are a few differences. So in general, with immunocompromised patients, they may become worse much more quickly compared with immunocompetent individuals. So empiric therapy is always warranted, while diagnostic workup is in progress. It's also very important to be aware of potential drug interactions because many antimicrobials can interact with immunosuppressive medications, placing patients at risk for increased toxicity or rejection of graft depending on the specific interaction. And one other measure, in particular with immunosuppressed patients, is the use of prophylactic antimicrobials to prevent certain infections, since these patients' immune system makes them more prone. The last topic we'll discuss briefly in this chapter is bioterrorism and respiratory infections, but we'll be addressing this again in the chapter concerning zoonotic infections. So remember, several of the organisms that we've discussed that cause respiratory infection are potential biological agents because they can cause mass mortality, and this has become an increasing important factor in the wake of anthrax attacks in the United States back in 2001. The CDC has labeled anthrax, plague, and tularemia as Category A bacterial agents, which constitutes the highest level of threat because all these organisms can be aerosolized for delivery to the respiratory tract. The initial clinical presentation of these pulmonary illnesses is similar to that observed with common bacterial respiratory pathogens, but then they can be fulminant and rapidly progress and become fatal. The causative agents of anthrax, Bacillus anthracis, the plague, Yersinia pestis, and tularemia, Francisella tularensis, need to be ruled out in the laboratory setting. And again, we will address this later on in the zoonotic chapter. But the important things to remember are that established protocols are in place to prevent infection from being transmitted to laboratory staff. And any suspicious specimens or isolates should be sent directly to the Laboratory Response Network for confirmatory testing, such as molecular PCR. The hospital clinical laboratory's main role is to rule out these potential bioterrorism agents.